Thank you so much, Clark, for this nice presentation, which collect the most frequent complications of the EVAR. So I think we will continue the presentations and we'll make the questions at the end of the session. So let's invite our next speaker, Professor Mike Wyatt.
Thank you very much for inviting me to this excellent meeting. I came 2 years ago and was unable to come last year, so it's a privilege to be able to join you again. I've been asked to talk about this topic, and it's electrical septotomy in type B aortic dissection. And I want to start by asking those who have done this procedure to raise their hands. 2. I'm fairly safe then in what I'm going to tell you, because there isn't a lot of literature out there, and I suspect that the results of people who've tried it haven't been published because they're probably not quite as good as the published literature. So I have no conflicts of interest. Now, chronic type B dissections are very complex and there's a challenging anatomy, and the natural history is progression and dilatation. And you also develop this very thick septum in the middle between the false and the true lumens. And the gold standard in management was always open repair, but that was associated with significant morbidity and mortality. And more recently, endovascular techniques have been utilized to try and help these patients, but they come with their own challenges. Now, TEVAR is often used and probably more frequently used nowadays than open repair for these patients. It's associated with a lower morbidity and a lower mortality. The idea of TEVAR is to cover the entry hole that has caused the dissection and to prevent the blood entering the false lumen lower down, and hopefully to prevent progression of the disease. But quite often there isn't only just an entry tear, there's tears further down that keeps the lumen open. And also the problems with TEVAR, it's quite often done fairly late, hence a chronic dissection, and the septum becomes very, very rigid, and it compresses the true lumen. And quite often the viscerals and the renals are coming off the false lumen, and it makes EVAR challenging, or TEVAR, in these respects. Now, when we were all doing open repairs, we quite often cut the septum from below to try and get a nice luminal diameter to sew a graft onto. And the very same is true for endovascular, in that you can use fenestration techniques such as the old cheese wire, which we used to do, which is quite rough and ready when you just put a guide wire over the top and pull down. You can use a balloon to rupture the membrane, or some people have described focused laser fenestration and penetration. And the aims are to completely obliterate that false lumen and to create a modern or a common aortic lumen to allow good fixation at both the proximal and the distal ends. Now, this was an early paper from Ann Arbor, and it described early experience of just aortic septotomy, not electrical, but aortic septotomy. It showed that it works. And they looked at 88 patients with chronic type B dissections who had TEVAR plus or minus septotomy over a 12-year period. And the results are this. The septotomy was to optimize the proximal and the distal lancing zones. And they did 31 cases, although it does say 30 on the diagram over there. I'm not quite sure where they lost one. And they had a very good technical success with this procedure. And if you had TEVAR alone, the technical success was less. You required more interventions, and there was less aortic remodeling. And I think following this, the aortic remodeling is really, really important. So they thought that standalone EVAR outcomes without septotomy for chronic type B sections had unfavorable outcomes. You needed to do more work. And if you could optimize the landing zones, you got a better result in the first instance and also in the long term. And it may actually improve the number of patients that are suitable for treatment with endografts. And this transcatheter electrosurgical septotomy has been described more frequently, but there's actually very little in the literature outside of the United States of America. And essentially, you've got a very small lumen there. You can see the true lumen and a large false lumen, and it allows for targeted thermal ablation of the central membrane or the septum, which is either vaporized or lacerated, depending on which process you use. And it's highly controlled with both fluoroscopy, echocardiography, and intravenous ultrasound techniques. And this article is still in press. It hasn't been published yet. It's from two groups in Texas, from Dallas there, and from Houston. And it's looking at the indications, the safety, and the effectiveness of this, what is quite a new technique, during the repair of aortic dissections. And they describe it, is this a pointer here? There isn't a pointer, I don't think. Anyway, they describe it quite carefully. They use IVUS to make sure that they're actually in the true lumen. And then they pass catheters up both lumens, and they capture the catheter, they perforate the septum, they capture it, bring the catheter down, the Astato catheter, and then they denude it a little bit of its polyurethane covering, put it back up, and they position it just at the top of the dissection flap. They provide power as they're gradually pulling the catheter down, and you can denude or destroy as much or as little as the membrane as you want to create either a proximal or a distal landing zone. And they describe 197 patients in which they've performed this procedure, but only 36 of them needed transcatheter electrical septotomy, and the majority of these were chronic dissections. As you can see below, they have had a few aortic acute dissections, but the results are less good. And they looked at technical success as successful septotomy without dislodgement of the membrane and without damage of the target vessels, and 30-day rates of major adverse effects. And they had technical success in 33 of 36 patients. And the failures were the acute dissections, which are far less stable than the chronic dissections. And also the lumen increased in each of these procedures to allow for effective stent graft placement. And also they did 18 FEVARs and BVARs associated with this, and they had successful incorporation of all 78 target arteries at that time. And this is just a little graphical indication of each of the patients. The sort of orange in the middle shows what the lumen was like for each of the patients before the electrical septotomy, and the red is what the lumen was like after. And you can see that the true lumen is significantly increased following this procedure. There's some early results published from this group in 2004. And again, it goes in to describe the procedure, which is not too complex and not too different from what people have done previously, although it's attached to the electrical force. And their first patients, before they joined with the other group, were 17, and they had 100% technical success. I always worry when people quote 100% and whether it's on an intention to treat basis or not. But they're very taken with this procedure, with no actual injuries and no visceral malperfusions, and also increase in size of the aorta and iliacs. And you can see there images from intravascular ultrasound and imaging of the aorta and iliacs at the top before the septotomy and at the bottom after the septotomy. And they looked at the long-term freedom from targeted vessel instability. And once you've done the procedure, that appears to be fairly good. There are also various case reports in the literature. And this is a complex one involving a full-length septotomy, electrical septotomy from the arch down to the infrarenal aorta. and this is in patients requiring a redo arch using an frozen elephant trunk procedure. And you can see the extent of the dissection in that image there and on the images, and the arteries coming off, the renal arteries coming off the false lumen. And this is just a diagram of how it's performed with the septotomy starting right at the top within the arch and coming down to just above the renal arteries to allow the frozen elephant trunks to be deployed in both the false and the true lumens, which have now become one. So in summary, ladies and gentlemen, electrical septotomy, it appears from the literature to be a promising technique for the treatment of chronic dissection type B abdominal aortic aneurysms. The early results in the literature are good, and it looks to be technically successful, and it looks to work well. However, there's no long-term follow-up. There's many case reports. There's only this one centre that I know that has got extensive experience. I know that there's been difficult experience elsewhere, and some of my colleagues have noted difficult experience. So we really do need to validate it. We need to have long-term follow-up, possibly registries, and compare it to known surgical techniques. Thank you very much indeed.